So my sort of talk today is kind of follows on a little bit from the one last night by Professor Gordon Guyatt. So it's on trials and observational studies, strengths and weaknesses. Okay, so this I use this slide here usually to look at methodological variation, but it actually works really well here because you can see here, and Professor Guyatt yesterday talked about many examples where observational studies and trials come up with different results. And this here is one more of those. And so here we've got meta-analysis forest plot, and it's been stratified into observational studies and trials. And so the area of research is not really my area of research, but that's beta-carotene and cardiovascular disease. And I believe that those first group of observational studies, they were done initially, and then it appeared that beta-carotene was protective for cardiovascular disease. And I believe that that was through what people ate. So I think beta-carotene is common in things like fruits and vegetables. And then after that, there were some RCTs conducted which showed the complete opposite effect. And when I see something like that, the first thing I think of is, well, I don't know if it's the first, but I eventually think about why is that? Why are those so different? And I actually don't know the answer to this particular example, but I could sort of speculate about a few things. So one of them would be that the people who eat a lot of fruit and vegetables with beta-carotene are probably going to possibly be more healthy. So maybe it's not really a fair comparison. Also, in the trials, I believe they got supplements rather than actual fruits and vegetables. And also, the trials you can see there, they've been conducted in more sort of higher risk type groups, except for maybe the bottom one. So those are some of the reasons why maybe you get this methodological heterogeneity. So moving on, I'm now going to sort of think about methodological variation in terms of NPIs. And so I'm going to think about it in terms of two hypothetical studies on masking for prevention of acute respiratory infections. So I'm going to say let one be an RCT and the other be an observational study. And so we're going to go through some of the sort of things about RCTs and also things about observational studies. So on the left-hand side, an RCT typically has got strict eligibility criteria. Not necessarily though, because some of the masking studies were cluster randomized trials, and so probably not so much with those. Also, the intervention gets randomly assigned. So what that means is that if the randomization works well, it means you're comparing apples with apples. Here's an important one here. In a RCT, such as for something like masking, participants may not comply or may not adhere to the assigned intervention, and that's certainly an issue in practice. The outcome could range from anywhere from objective to subjective, so it could be just self-reported respiratory infections right through to laboratory-confirmed influenza or COVID, for example. Also, another important factor is that with an RCT, often other interventions would be balanced across the groups. So if you compare that now to a case control study, which is the ones that have often been done in the past for masking, here we have people where the outcome selected as the cases, so the people who actually got the acute respiratory infection. And then they're matched with controls. And so here I'm starting to think, well, there's potential there for a bias because it depends on how well we match the cases to the controls, and often we don't know actually how well they are matched. Also, and the next thing is the exposures are based on, so that exposure would be whether you wore a mask or not, are based on often retrospective self-report. So there could be potentially some bias there. Once again, the outcome could range anywhere from objective to subjective. And the last one is possibly the most important, I think. the people who wear the masks may also use other prevention measures, so things like hand washing and social distancing. As I'm now going to present a couple of meta-analyses of studies that I was involved with where this is a 2011 systematic review looking at physical interventions to prevent respiratory virus spread. And so this group of studies here were all case control studies, and I think they were run during SARS-1. And you can see here on the right-hand side, there seems to be very strong evidence of a protective effect in terms of acute respiratory infections. And that odds ratio there, 0.32, and very tight confidence interval, sort of implying that masks reduce the odds of infection by about 68%. Now, this Cochrane review has been updated in 2020 and also in 2023, and so this is kind of the latest version of it. And you can see here, once again we've got looking at masks versus no masks, but here we decided in 2020 we would not include the observational studies because we thought they may be unreliable. And so we focused just on randomized controlled trials. You can see here a whole bunch of trials, and the outcome here was influenza or COVID-like illness. And you can see here we've got this methodological heterogeneity. So now we've got a risk ratio of 0.95, quite a tight confidence interval, and insufficient evidence to show that masks are useful. So then maybe the next question you might think of, or I thought of, was, are observational studies useless? Well, not necessarily. I think they're certainly more difficult to get right compared to RCTs, but certainly in recent times there's been a lot of research into better methodologies for observational studies. So one example would be trial emulation, where the idea is to make an observational trial as similar to the observational study is similar to a trial, and hopefully can make causal inferences, but need to be aware of potential for specific biases. So I'm going to talk a little bit about that there in a few slides. And I'm going to this is an example of a study where I found the study really interesting, mainly for one thing, and that was they were able to sort of show that their matching actually was really effective. And that was because, so this is a study looking at the Pfizer vaccine, an observational study conducted in Israel, and I think it was published in 2021. And so we see here they matched the vaccine recipients and controls on variables associated with both vaccination and infection or severity. And they included things like age, sex, ethnicity, neighbourhood of residence, history of influenza vaccination, pregnancy, and also coexisting conditions. And the thing about it I thought was really interesting is this plot here. So because the vaccine takes a certain number of days, let's say around 10, I don't know exactly how much it is, for the effect to take hold, I guess, or for it to work. I don't know. I'm not a clinician, I can't get the right language. But you can see there that this is a cumulative incidence of SARS-CoV-2 infection, and you can see for the first 10 days they overlap each other. So I think this is a case where we can actually match and we can actually see how well the matching worked. But I think it's unusual. And so I'm going to move to another thing that I talked about a couple of slides ago, and that is that it's really important to be aware of specific biases in observational studies so that you can mitigate against them. So this is a particular type of bias that I came across when I was involved in a Cochrane review systematic reviews on antivirals influenza. And we looked at observational studies, and one of the team members, who's a physician, not a stats person, he told me about this immortal time bias, which I'd never heard of before. And it turns out that this is really, really important and needs to be controlled for in observational studies. So I'm going to just kind of try and explain it here. So in hospital-based studies of influenza, the patient will be sick and be admitted to hospital or present to hospital, and then sometime after that they may or not get a prescription for an antiviral. So, but in that time, they could actually die. So what that means is that, and this creates this thing called an immortal time bias. And so, and it can actually change the effect, the estimate of effect from, let's say there's it's a harmful intervention, it can actually flip it and make it look effective. And so I'm just going to give an example of how much impact it can have. So as part of our systematic review, we asked the authors of the included studies if they could give us their data. And this data actually comes from Canada. And so here this shows time to death or proportion surviving. And it shows two groups. And the group there with a dashed line that's the group that got Tamiflu, which is an antiviral. And the other group didn't get the intervention. And so it looks there pretty clearly that Tamiflu was effective at preventing death. However, that study had immortal time bias. And so when you take account of that, it actually shows that there's really no difference between the two groups. And in fact, in all the studies we looked at, if we meta-analysed them, we found that there was really no association, I shouldn't say effect. But RCTs can have problems too. So I'm going to present another example of a study I was involved in, also looking at antivirals for influenza, but this is all based on clinical trials. And so in this particular review, we obtained the clinical study reports, which is quite unusual back then anyway. And so all these studies down here on the left, they're all studies, some of them were published and some of them weren't, and they're all on two types of antivirals. One's called Tamiflu and one's called Relenza. And so we were particularly interested in this outcome of pneumonia because it appeared that these antivirals were protective for pneumonia. But because we had access to these clinical study reports, we could actually drill down and find out exactly how they measured the outcomes. And so in this first group of studies here, they all had, pneumonia was like a tertiary outcome, and it was based on self-reports from clinical diagnoses. Whereas a subgroup of the studies, they actually measured the outcome much more objectively and had X-ray confirmation. And you can see here that when you split the data up into that, there appears to be some methodological variation. So the studies that had the less reliable outcome measure, they showed a highly protective effect, whereas the others didn't. And then I was particularly interested in this because I wanted to know, why is that? Is this like a chance finding? Because these are all placebo-controlled, blinded studies. But I had a look around in the literature and found the study, which I found really interesting. So this is where, it was a European study where they looked at patients who had been either clinically diagnosed or not diagnosed with pneumonia, and then X-rayed them. And what they found is that there were the two columns there on the left-hand side, those are the group of patients that were clinically identified and had pneumonia. Whereas on the right-hand side, they were clinically unrecognised, but they had pneumonia. And some of the factors, if you look down there, one that struck out for me was fever. And so you can see there that in the clinically identified group, 90% of them had fever, whereas on the right-hand side, the ones that were unrecognised, they was much lower percentage. And the mechanism of action for antivirals is to reduce fever. That's one of the things that they do. So I thought I don't know if this is an explanation, but it's definitely plausible that if you're not measuring pneumonia objectively, then you could be missing pneumonias in the people who got antivirals because they didn't have a fever. So potential mechanism for why that could have happened. And just lastly, my very last point, however, it's my most important one, I think, is irrespective of study design, need to be aware of conflicts of interest and investigators with strong prior beliefs. Okay, so I'm going to stop there. Cool.